Um, so welcome everybody to this webinar. I always forget how many we've done, but we've done quite a few now. And I always start by saying that if anyone's got ideas for future webinars, please get in touch with myself or Sarah. Before we start, just to draw your attention to our conference, which is in November, early November this year, and the abstract deadline is in July. So just bear that in mind, and we'd be looking forward to seeing you in the Gold Coast, which is where it will be held this year. And also to note that Sarah's just put out the advert for nominations for our, well, we've got a whole range of awards and prizes for best papers, best researchers at different stages of careers. So just head on to the website and you can see details of those awards, and we welcome all applications. So today we've pleasure to welcome Kees van Gool, who's going to talk to us. And it's a pleasure to welcome Kees, who's is a highly regarded and influential health economist here in Australia, also Deputy Director of the Centre for Health Economics Research and Evaluation at the UTS. He's probably one of the few academic health economists who's worked both in the national government and also state health departments, as well as internationally at the OECD. So he's got a wealth of experience and a particular interest in how healthcare systems are financed. And so today he's going to talk to us about the fees that are set by GPs and specialists within the Australian healthcare system and policy-related issues. So thanks, Keith.
Sorry.
Just to note also, yeah, that if you have any questions, if you think of questions as Keith is talking, you can put those down in the Q&A or the chat boxes, and I'll relate those to Keith at the end of the seminar.
Great.
Will you say something else, Sarah?
That was it, yeah.
That was it. Thanks.
Thanks, John. Thanks for that introduction. Yeah, so thanks very much for the invite to talk to you about a few papers that we've done and have published, and trying to sort of bring a few of those ideas together to really look at what we think are the policy implications from our research. And I suppose we started thinking about this when I was at the OECD, and one of the things you always learn when you're out of the country is to sort of see how unique your own country is. And so one of the things we really started getting interested in is how what doctors' behavior is like in a system where there is such lack of regulation with regards to fees. And so that's really the motivation behind the paper or papers, while Sarah helps me get to the next slide.
Yeah. Why is it? Okay. Keep talking. I will ask.
Sure. Okay, hang on. I know it's working, Sarah. It's fine. It's working? Yeah. So these are in fact the three papers that I'll be drawing on just for your reference. A couple of papers that have recently come out in health economics. Okay, so the government, this is sort of goes back to the Constitution in many ways, but this is a nice quote from the Department of Health that they said in the Senate in 2009, which that the government has no authority to control the amount doctors charge for their services, as this would amount to civil conscriptions. Doctors are free to determine their own value of their health service or the health services that they provide. So the question is to what extent do doctors use this freedom? And that's an important question, because obviously in Australia's Medicare system, the prices that they charge are very closely related to the out-of-pocket costs that people pay. And so therefore that has a direct implication on equity of access and financial access. But of course, prices also are very important in terms of efficiency and overall expenditure. So we'll look at that, and that's a fairly descriptive piece of work that we'll describe for both specialists and GPs. And then a second part of the presentation today is going to look at how government policy reforms back in 2003-04 have actually influenced how doctors actually do charge their patients. So a quick outline of the presentation for the next 30 or so minutes. We'll set the scene, and I do apologise if that covers some of the materials that a lot of you already know about and are familiar with. Then we'll look at some fee gap papers. First of all, the paper that Meliani wrote about general practitioners, and then we'll focus on specialists. And then, as I said, we'll look at the paper that examined the impact of policy change on fees and co-payments. And then finally, we'll wrap up with some conclusions and implications where we think what the research is pointing to. So setting the scene. Well, Medicare, we're basically talking about Medicare in the context of the MBS, the Medicare Benefits Schedule. That's the focus of all the work that I'll be presenting today. And as you know, basically all Australians, permanent residents and visa holders are eligible for Medicare coverage. The Medicare coverage is defined by the Medical Benefits Schedule, the MBS. Used to be a big, thick printed book of around 5,000 items. And each of those items came with a description of what the service entailed, as well as a schedule fee for which what is in fact the government subsidy for that particular item. Now, it covers both out-of-hospital and private inpatient services, but today's focus will be on out-of-hospital services only. Now, generally, the government rebate is about 85% of the schedule fee, but since 2005, for all primary care or GP-related consultations, that percentage is, in fact, 100%. Now, here's the important bit. Doctors are not constrained by the schedule fee. And in fact, when I was at a international organization, that's the point you have to keep on reminding people that doctors can charge whatever they like. That there is no other type of insurance available for out-of-hospital services. So, in fact, whatever the gap is between what Medicare pays and the doctor's fee, patients are in fact responsible for. And so that's close, therefore that's that link between doctor's fees and out-of-pocket costs. Now, there is a safety net in place as well, which provides for additional protection, but that only affects about 1 in 20 Australians who qualify each year. So, 95% of us don't actually qualify for safety net benefits. Now, these are just some very recent graphs of trends in GP land as well as specialist land, which I'll show you in a minute. But it shows you the trends in terms of the bulk billing percentage, the average out-of-pocket cost, and the average fee for GP attendance over the last, since 1992. So you can see that the bulk billing rate is fairly high. So it dipped somewhat in around 2003, but has been increasing basically ever since. There's a slight dip at the moment, but that's a very, very slight. But essentially around 83% or even more, 83% of GP consultations are bulk billed, which basically means that patients don't face any out-of-pocket costs for those services. But the fees have increased, and the green line is the average fee that a GP charges, and the orange line is the average out-of-pocket cost that a patient faces if they are not bulk billed. And you can see that that's been increasing quite steadily since about 2004 as well. You can see that blip here as well, the rise in the in the fees. And that, of course, is the effect, which we'll come to later in the presentation, of the strengthening Medicare reforms. In terms of in terms of specialist consultation, well, the first thing to note, of course, is that the bulk billing rate is much, much lower than GPs. In fact, it's around about 30% compared to the 83% I was mentioning before, and it's been fairly steady over the at least last 10 years. Fees, of course, are much, much bigger and are much higher than GP consultations. And also the gap between the fees and the Medicare rebate is much higher, which results in a much higher out-of-pocket cost than for GP. So much lower likelihood of getting bulk billed for a specialist consultation, And for those who are not bulk billed, the average out-of-pocket cost is much higher as well. Now, previous evidence, previous research on prices or fees and out-of-pocket costs. Some work that Glenn Jones, Elizabeth Savage and myself did about concession cards and their protective effect show that concession cards do protect patients on total out-of-pocket costs for GP-related services, but not specialists. Working with data from the longitudinal study of women's health shows that there are higher fees mainly explained by lower bulk billing in rural and regional levels, but that gap has been falling. So in fact, things are better in the bush now than they were previously. And some work here done by Richard at the centre on a survey that we conducted shows that the likelihood of GP bulk billing shows that it's less likely the larger the practice size, higher the income and living in inner and outer regional areas, but more likely if patients have a concession card and suffer from multiple chronic diseases. There's some recent work which came out just a few weeks or months ago in the MJA, shows that is substantial variation in the fees charged for both in-hospital separations, and the example there was hip replacements, where there was a huge range, explained by a number of factors, including the cost of the prosthesis in the case of hip replacement. But then also some widespread variation in initial consultant physician fees, item 110 on the MBS, where it shows that there was a variation in fees across and within specialty areas. Now, the work that I'm going to focus on now is slightly different to that, because what we looked at is within variation. And what I mean by that is that we looked at what a doctor charges their high-income patient and their low-income patient, and measured the gap of that doctor, and then did some analysis of that. Now, we looked at to do that, we used the 45 and up study, which is a New South Wales-based study of 260,000 people. One of the great aspects of the 45 and up study run by the Sachs Institute is that it is linked to a large number of administrative data sets, including Medicare and the MBS. And what this paper did was it took item 23 and extract all the GP fee information for item 23. So we're comparing like with like. Item 23 is the most common GP item used and billed in the Medicare data. And so what we looked for each individual GP, of whom there were 7,500, we looked at what they charged their high-income patient, and then we looked at what they charged their low-income patient, the top 25% and the bottom 25% of the income distribution. And then we just subtracted one from the other and said, well, here's a gap. And so each individual doctor had one data point, which was the gap between what they charged their high-income patients and what they charged their low-income patients. And therefore, that's why it's a within analysis. And these are the results. So just to explain this graph, at the bottom end, on the horizontal axis, what we're measuring is that gap. So 0 there means that the doctor is not charging their high-income patients any different to their low-income patients. But if there is a positive number, so anywhere along to the right of 0, it means that they are charging their high-income patients more than their low-income patients. And whereas any number to the left is in fact the reverse. They're charging their low-income patients more than they are charging their high-income patients. And this is the cumulative distribution. And so it shows the percentage of doctors who are charging these gaps. Now, there is a small number of doctors, probably less than 5%, who are actually charging their low-income patients more than their high-income patients. Then there is about 35% who are not discriminating at all in their charging. So there's no gap between their high-income and low-income fees. And then about 60% are actually having some form of price discriminations where they charge their high-income patients more than the low-income patients. Now, the median gap is about $5, and about 20% of doctors charge $10 more to their high-income patients than their low-income patients. And the work that Meliani did was she accounted for a number of factors based on GP quality, area income, and that doesn't reduce the gap at all, but the amount of competition within the area, so the number of GPs within the area, within a regional area, does reduce the gap being charged by GPs for their high and low income patients. So that's the story for GPs. The story for specialists is similar. We applied a very similar methodology where we looked at item 104, which is MBS item 104, which is the initial consultation. So again, trying to compare like with like. Now, here we found that 16% of specialists always bulk bill, regardless of the income of their patient. And we had to exclude, obviously the same thing as in the GP land, but it became a bigger restriction here. We had to exclude those specialists who didn't see both a high income and a low income patient. And that reduced the number of specialists by quite a significant amount. So in fact, that was possibly the biggest criteria which reduced our sample size. But in the end, we still had well over 2,000 specialists who we could compare the price gaps for. And these are the results for specialists. And so here, there's around about 5% of patients, 5% of specialists, I should say, who charge their low-income patients more than their high-income patients. Then there's about 16%, as I said, who don't price discriminate, and then everybody else is to the right of that zero gap. And so I think the average gap is around about $26. And obviously, around about 20% of the population, the specialist population, the gap between high and low income patient fees is in excess of $50. So looking at that in a little bit more detail, here's the average charge for high income and low income and the fee as measured there. So for all, so the gap there is around about $26. And that varies a little bit depending on where, on the region that where the specialist and the patient resides. Sorry, Sarah's just doing a little bit coming to my screen.
Got rid of you completely.
Okay.
Is that okay?
It's fine by me. It's good. I can't see myself. As you can see, for socioeconomic status, so these are the most disadvantaged area and these are the least disadvantaged area. As you can see, the fees go up, which is not surprising. So in wealthy areas, the average fee is higher than in the lower socioeconomic areas. There is, however, a remarkably consistent gap between what specialists charge their high income and low income patients. So whilst the fees are slightly lower for low income patients everywhere, they also rise in almost equal amounts as you move into higher socioeconomic regions. Now, to be honest, when we did this analysis, I thought, well, you know, one of the big questions is how do specialists actually know their patient's income? How on earth do they actually implement this sort of price discrimination? And my hypothesis when we started this was that, in fact, it could all be explained by concession card status, because that's obviously something that specialists can observe. So I, in fact, expected that once, we've gone, I can't go to the next slide. So I'll continue. So I expected that once you account for concession card status, in fact, we would have very little difference. That would explain the biggest difference between high and low income patients. So I, in fact, was kind of expecting, if you're a high income concession card holder and if you're a low income concession card holders, that those fees would kind of be the same. And if you're not a concession card holder and high income, and you're not a concession card holder, low income, they would be roughly the same as well. So all the variation would really be explained by concession card status rather than income, because that concession card status is something that the specialist or the office can observe and frequently asks for. Turns out I was wrong, as in many instances, because in fact it explains some of the difference, but certainly not all of the difference. So as noted before, the average gap between high and low income is around about $26, and by accounting for concession card status, that gap now is somewhere like $22, $23. So it explains some, but certainly the majority of the variation is not explained by concession card status. We did similar things. We did it again. We looked at whether private health insurance was a factor, whether age was a factor, whether labour force participation was a factor. All of them explains some of the variation, but by no means the majority of the explanation. And in fact, for this one, there's absolutely no difference for high income people, whether you have private health insurance and no private health insurance. In fact, the fees is completely different. But for low income people, there was a slight difference between having private health insurance and no private health insurance. And remembering, we're still talking about the within gap variation. Okay, so that sort of concludes the price variation part of the work, and now we'll turn our attention to the strengthening Medicare reforms that were introduced and implemented from 2003 to 2005 onwards. Now, casting our minds back that far, there were three main reforms, which was the introduction of the Medicare safety net, an incentive for GPs to bulk bill children and concession card holders, plus there was an additional incentive for if people lived in regional areas, as well as an increase in a Medicare benefit to 100% of the schedule fee. Now, there was a slightly staggered approach to the implementation. We're not going to focus on the Medicare safety net today, but we'll focus on the incentive for GPs and the increase in the Medicare benefit. And those two reforms were implemented in a staggered manner. One was introduced in March 2004, and then roughly 9 months later, the other one was introduced in January 2005. So just to give you a little bit more detail about those two reforms. So the first one, which we'll call P1, was the Medicare the GP bulk billing incentive. And at the time, if you lived in a metropolitan area, a GP would be able to claim an additional $5 if they bulk billed a concession card holder or child under the age of 16. The incentive increased to $7.50 if the patient lived in a rural or remote or outer areas, which included places like Tasmania. For the general population, so basically everybody else who's an adult and doesn't have a concession card holder, there was no change. So it only applied, that incentive only applied if the patient was a concession card holder or a child and was bulk billed. And then P2, the second incentive in GP land, was that just a general increase in the rebate, which in effect was from going from 85% to 100% of the MBS schedule fee, which in fact is basically a 17.6% price rise that was paid for by the government under the strengthening Medicare reforms. So how do we analyze this? Well, it was sort of a difference in difference approach, but not quite, because it's not as clean as the previous table outlined. Some of it is not as clean. We have some variation in terms of how the incentive was applied to specific groups and within specific regions. for the first incentive, so that's good. But in terms of the second incentive, it applied to everyone, and so it's not a difference in difference model in that sense, because we only have really before and after experiences to analyze. Nevertheless, we looked at this equation, and so we looked at what was the average out-of-pocket cost, and the benefit and the fee in different models. So let's say we looked at out-of-pocket costs, and then we looked at the impact of the first incentive payment, and we looked at whether that incentive payment was different in regional areas, because after all, there was a different incentive. And then we looked at the impact of P2, the increase in the rebate for everyone, and whether that had a difference impact in regional areas. We also had a number of control variables, and of course we accounted for the various time factors as well. And because the incentives applied differently for concession card holders and the general population, we run two different models, one for the concession card holders and one for the general population, and we compare what the impacts were for P1 and P2 to get an idea of the differential impact between the concession card holders and the general population. Then we repeated that analysis, and we looked at some subpopulation analysis just to see what happens to certain groups of patients. And in particular, the results I'm going to show you is to sort of see what happens for different patients who had different experiences in their co-payments and out-of-pocket costs before the strengthening Medicare reforms. So basically, we divided the sample into 4 different groups. So people who had experience of where their general average out-of-pocket cost was less than $1 per consultation. So these are primarily the people who are bulk billed, and we looked at them before and after the Medicare reforms, and then also looked at patients who were typically charged between $1 and $6 in out-of-pocket costs, and $6 and $12, and greater than $12. Now, the data we used for this analysis was the Australian Longitudinal Study of Women's Health, which is a national representative sample, which commenced in 1996, which of course is important because we need data before and after the strengthening Medicare reforms were implemented. It has 3 age cohorts for women who were born between 73 and 78, 46 and 51, 21, 26. And importantly, just like the 45 and up data, it also is linked. It has a survey component, but is also linked to Medicare Australia data. The way we use the Medicare Australia data is by looking at individual level quarter by quarter. So we had a number of observations per woman, ranging from quarter 1, 2003 through to quarter 4, 2005. So about 3 years worth of observations, with the strengthening Medicare reform sort of falling right in the middle of that. We looked at all their GP-related services, Medicare benefits, doctor fees, and out-of-pocket costs. We had their location through the postcodes, which we then linked to the rural remote indexes as well as socioeconomic indexes. We also used the PBS, linked PBS and survey information to ascertain whether they had a concession card status. And we imposed a few exclusions, which was related to whether they died during the observation period, whether they switched concession card status during the observation, and also just for those observations where there was 0 GP in any relevant quarter were also excluded, but only for that particular quarter. So the sample, not all the women in the Australian Longitudinal Study of Women's Health actually consent to having their data linked to the MBS, so that's a bit of a limitation. But in the end, there are about 10,000 women in our sample. And as you can see, there's quite a bit of difference between the age and the education level, as well as other socio-demographic variables between the concession card status and the general population, which is, as you would expect it, but certainly also justifies why it's good to run separate analysis for these 2 groups. Okay, so these are the results of the of that equation 1 that we showed you. And just to help with the interpretation, so the constant really is the average out-of-pocket cost per consultation right at the start of the observation period. So that's really Q1 in 2003. So concession card holders generally had around about $3.67 in average out-of-pocket costs, and whereas the general population had an average out-of-pocket cost of around $8.91. And then we, of course, we allow time to move on, and we account for that through our time variables. But these are in fact, the variables of interest. So, in fact, the bulk billing incentive reduced the average out-of-pocket cost by around 5 cents per consultation in the areas, in the cities, whereas in the high incentive regions, it reduced the average out-of-pocket cost by about 43 cents. And then when the 100% rebate changes came in, the average out-of-pocket cost fell by another 34 cents for the cities and another 43 cents for those living in the regions. Now, if you look at the general population, though, so everybody who's not a concession card holder, you see quite a different experience, and we'll focus on that a little bit further in a little while. But obviously, the rebate did have an effect on the out-of-pocket costs, so falling by about 94 cents, average out-of-pocket costs falling by about 94 cents in the cities and 68 cents in the regions. But in fact, the bulk billing incentive had the effect of increasing average out-of-pocket costs by about $1.23 for the general population, and no significant change for the regions. Now, I would have expected perhaps no change, because obviously the general population wasn't eligible for the bulk billing incentive, but I wasn't expecting a positive change. Now, when you run the models for out-of-pocket costs and Medicare benefits and doctor fees, we get an aggregate sense of what the strengthening Medicare reforms actually did. So this is comparing the last quarter that we have data for, 2005, running the models and then comparing that to 2003. And so in aggregate, in the metro areas, average out-of-pocket cost for concession card holders fell by 39 cents, but the Medicare benefits increased by $10.66, and most of that was actually, so in fact, you would have hoped that a larger share of the increase in the Medicare benefits actually went to reducing out-of-pocket costs, but in fact, what actually happened was most of it went into higher doctor fees. Now, that's not entirely surprising, because obviously, even at the depths of 2003 and the bulk billing rate, still well over 70% of consultations were bulk billed. And so you're actually increasing with the incentive. You're not invoking any behavior change, and you're still paying 70% of all GPs an extra $5, or in the metros an extra $7.50. So that lifts the price that doctors charge automatically without any change. Now, in terms of general population, we actually see a small increase in out-of-pocket costs, and that again is explained by the effect of the extra Medicare benefit increasing the doctor's fees by, in fact, more than the Medicare benefits. Similar story in the regions, but slightly for the concession card holders, but a slightly bigger impact in terms of reducing the out-of-pocket costs. Now, here's looking at this in a little bit more detail of who was affected by this. When we split our sample up according to what their average out-of-pocket cost experience was prior to the reform. So in this first set of graphs, we're looking at concession card holders and so concession card holders on the left-hand side and non-card holders on the right-hand side. And we're looking at women who had less than $1 in out-of-pocket cost per consultation prior to the Medicare reforms. And then we look at the incentives, the bulk billing incentives that were introduced in 2004, and then the increase in the MBS rebate in January 2005. Now, obviously, people who don't experience any out-of-pocket cost prior it can't fall any further, so there's not much change. But what you can see here, though, for the non-card holders, there was a change, a positive, an increase in the average out-of-pocket cost for non-card holders. And here we see the effect of what I think is the effect of the strengthening Medicare reforms and actually having sort of a further price discrimination that has been reinforced by a policy change. When we look at women who had an average experience in out-of-pocket costs between $1 and $6 prior to the reform, we see that concession card holders, slight decline in the average out-of-pocket cost, and still seeing that increase in average out-of-pocket costs for the non-card holders. So again, women who were experiencing these types of out-of-pocket cost experiences prior to the reforms showed an increase in their out-of-pocket costs after the reforms. Then going up the ladder in terms of the average experience, the decline here is certainly setting in, so it did have an impact on out-of-pocket costs for women who had between $6 and $12 in 2003. And here we no longer see that jump, and in fact it's coming down a little bit after the introduction of the second reform. And here, definitely a decline in the out-of-pocket cost for patients who are experiencing high out-of-pocket costs of greater than $12 per consultation, and smaller decline for the concession card, for the non-concession card holders. So, what are the implications? Well, bringing all those papers together, we can definitely see that doctors in an unregulated fee-setting environment charge higher fees to higher income patients. Now, some of that is explained, but not a lot is explained by the patient characteristics. And even within that, those patient characteristics seem to be more important for low-income patients than for high-income patients. Now, the way we've done this is we only looked at this one way at a time. So we only looked at the impact that having a concession card has on price discrimination. Then we looked at what the impact of age was and the impact of private health insurance and the impact of labour force participation. We only did this one set of characteristics at a time, whereas of course it is entirely possible for doctors to use a multiple of proxies of income simultaneously. But that's another research question which we'll get to in the fullness of time. I presented this paper at the Department of Health once, where one audience member was indicated that there might be other proxies that are harder to observe in our data, including the idea that perhaps the fact whether he had experience of a practice he used to work in Queensland, and they price discriminated on the basis of whether the patient wore shoes or not. I don't know how common that is, but it's obviously not observable in our data. We can only stick to what we can and can't, what we can see in there. Now, the evidence that we're sort of showing here is that this fee gap between high and low income patients is consistent with price discrimination and profit maximization if low-income patients are more price responsive than high-income patients. And all evidence suggests that that is, in fact, the case. But of course, it's also consistent with our kind of bleeding hearts hypothesis, which is that doctors care about the equity and the financial access that their patients have. Now, I think that that's possibly true in the GP world, but I think we can start to discount that a little bit more in the specialist world, where even though there is price discrimination, and even though lower income patients have lower fees than high income patients, those barriers still remain. And so despite the fact that it's lower, there are still substantial financial barriers for low-income patients to go and see a specialist. And we see this from previous work that Eddie van Doorselaar has done in Australia, where there is a pro-rich distribution of specialist use, but also some work that we're doing at the moment, where we can see that low-income and high-income patients really navigate the healthcare system in very different ways after they've had a health shock, like the diagnosis of diabetes. And so we would still argue that even though the bleeding heart explanation may be a factor, obviously they're not sufficiently bleeding hearts enough for the financial access to become equitable. So also in terms of the strengthening Medicare reform, we saw definitely some reductions in the out-of-pocket costs. And in fact, you know, the increase in the bulk billing rates have been widely accredited to the strengthening Medicare reforms. But it definitely, the experience from that analysis shows that the out-of-pocket cost changes are very much dependent on whether or not you have a concession card, whether you are a concession card holder, and of course also your prior experience. And so we saw that a large number of groups actually saw their out-of-pocket costs rise after the strengthening Medicare reforms were introduced. Now, we also saw that there was significant leakage of government benefits. So a large proportion of the government benefits that were implemented into or were put into the Medicare, strengthening Medicare reforms actually went to higher doctor fees rather than out-of-pocket costs. And we can definitely say that there was a stronger emphasis on price discrimination post-reforms than there was prior to the reforms. And so what we can say is that, in fact, perhaps the strengthening Medicare reinforced the role of concession cards for targeting out-of-pocket costs. Now, one of the things that I think is worth highlighting here is that, of course, concession cards are a very dichotomous instrument. You either have one or you don't. And it's not particularly targeted at income. So it protects the elderly, basically almost, you know, a large proportion of those who are retired or over the age of 65 have a concession card. It protects the poor. If you're under 65 and you have a very low income, you also have a concession card, but it also protects the middle class, because even reasonably wealthy people who are retired also have access to a card. So using the concession card as as an instrument to target policy can create some barriers if you don't have one, and you are sick, and you are on a lower income, but don't have a concession card. Now, finally, I just want to sort of ask the question: well, what's wrong with price variation anyway? What's so bad about it? And I think that it's not a straw man question. I think there is a reasonable question to ask there. But there are certain circumstances where you can imagine that price variation is actually perhaps not that bad. If you can have price variation which is well targeted and does not impose a barrier to access for lower income people, then perhaps having a higher price for higher income patients may not be such a bad thing. But of course, that's a big question of whether that actually occurs or not. And of course, prices are very much linked to expenditure and overall expenditure that government as well as patients pay to the healthcare sector. But on the profit, so if we think about the causes of price variation, and we think about the profiteer motivation, well, some of it can be explained by perhaps different willingness to pay, and it is doctors' ability to extract economic rent or profit on the basis of variation, being able to classify people who are willing to pay some more versus those who are not. It can be explained by monopolistic competition, and where there is a bit of product differentiation. You know, if you don't go to a bulk billing doctor, you might have less waiting times or less time sitting in a waiting room, or you may be able to make an appointment, whereas others you may not be able to make an appointment. Now, there's sorts of things that I think Australians might be okay with in terms of product differentiation, but it might become more of an issue if that product differentiation goes down the line of quality and quality of care. Then, of course, there's another explanation of why this sort of price variation may occur and would actually be a problem if it is all to do with the fact that the transaction costs differ so much. Price information is hard to come by and is costly to get in Australia, particularly for specialist care, where in most instances we don't really know what we're going to be up for in terms of out-of-pocket costs before we go to a specialist. It requires a very active patient to go and ring around and ask the questions about what the fees are. Then they have to work out how much Medicare would pay back and work out what their out-of-pocket costs are. Then they have to do that multiple times. They might have to go back to the GP to get a different referrals. There are very high transaction costs to actually getting the right sort of price information out there. And so if you don't have, if those transaction costs are a barrier to sort of effective competition, then that, of course, is a barrier. Then, of course, there's restricted entry to markets. You know, we know that it takes a long time to get a degree in medicine. There are barriers to get qualifications, and these are controlled by the colleges. But another factor is that we can't discount is, of course, the bleeding heart argument, and that the equity of access is a factor in and a motivator for doctors to charge different prices to different patients. And that then gets us into some sort of idea that doctors might be cross-subsidizing their care, that in fact the cost of providing care sort of falls somewhere in the middle between what they charge their high-income patients and their low-income patients, and that in fact it's the cross-subsidization that allows them to get going. Now, everybody, I think, who's listening may have an idea of whether that is truly occurring or not, but in truth, I don't think anybody has any answers to what extent that is happening. And so, whilst I think those two things, or those two motivations that could be sitting behind this price variation, does lead us to have to be cautious about the policy recommendations. So, to me, I think one of the things that comes out of this is the concession cards. So the concession card could be described as being too blunt an instrument to actually target a lot of your policies around. There's too many low-income people who don't have a concession card, and perhaps too many high-income people who do have one, to be able to target your incentives and strategies effectively if that's what you're trying to do. I think there's a greater need for transparency to improve price competition, but what if that also reduces cross-subsidies? So the worst case scenario would be that improved price competition and improved transparency reduces the prices at the top end, but increases the prices at the lower end. So, you know, prices for high-income people are coming down because of the competition, but in effect, the cross-subsidies are no longer now working, and so the prices for the lower-income people are going up, and that would be an undesirable impact. We can't tell, I think, at this stage about whether that would happen, but there is a risk there that it could. And so I think that one of the other incentives that we need to look at is to try and incentivize bulk billing to a greater extent in this country, to perhaps extend the GP bulk billings to also specialists. Now, the way you implement that is, of course, there's many variations on the way you could do that, but you could align that to income. It doesn't have to be aligned to concession cards. It could be aligned to disease status. It could be aligned to some sort of safety net. But of course, what you would get is you'd get more bang for your buck in the specialist land with these incentives than you would in the GP land, because of course it only would, the incentive would only actually work if there was a behaviour change. And we know that only 30% of specialists bulk bill, and so you'd actually get it. You need to get a change in that 30% in order to actually get the incentive, and therefore you would get more bang for your buck. But all this sort of points also to a rich sort of research question around insurance design, because one of the things that we don't really know is how different groups of people respond to different types of incentives on both the patient and provider side. And so I think whether the incentives or billing incentives, safety nets, rebates, all those things, how they all come together and how they create incentives for different types of patients, low income, high income patients, and what that does for how they actually interact with the system is a very important question that we hope to do more work in the short term. So that's basically it. Just a few acknowledgements with respect to the data that we used. So I'd like to acknowledge the University of Newcastle, University of Queensland for their assistance with the longitudinal study of women's health, and of course the Sachs Institute for the 45 and up study, as well as all the participants. And our funding source was the AFCRI, Centre for Research Excellence in Financing Economics in Primary Care. So I'll leave it at that and be very happy to answer any further questions.
Thanks, Keith. That was, yes, one of those presentations that raises a lot of questions whilst also giving a lot of new information. So thanks very much for that. We've only got one question at the moment. If anyone else has got any questions, please put them in. We've probably only got about 10 minutes. Actually, the question isn't really a question. It's just asking about the references. So maybe if you can maybe just flick back to the first slide that's got the references so people can get some more detail from those. I had a few questions, well, quite a few questions that came. I guess the first one I was interested in is more of a policy question about why can't people get insurance for the gap between GP and specialist fees?
That's a good question. I think it's been historically, there's been a mix. So historically, there's no real answer because we have had, MBF used to be the insurance funds which covered medical fees and medical services. Now, I don't know whether, of course, there is that insurance ability for inpatient, but we do tend to distinguish inpatient and outpatient. The one thing I will say, of course, is that the government provides additional insurance since 2004 through the safety net. Mm-hmm. And that was back when that was implemented, that was kind of seen as additional insurance for out of hospital services. But yes, you're right. There is no additional private insurance that you can buy, and I don't really know the historical reasons behind that.
Yeah, well, I mean, so presumably then the insurance companies just judged it not to be a profitable area for them to provide a service.
Well, I think they're legislated not that they can't.
Oh, it's legislation.
Yeah. So they can't offer it. They can only offer out of hospital insurance for things that are not listed on the MBS. So typically things like physiotherapy or obstetrics, ophthalmology. Glasses.
Yeah. Okay. That's okay. All right. So Bernie Ward has asked, during the study period, the eligibility for concession cards has tightened a lot. Can you comment on how this might impact on the validity of the results?
Well, yes. So that would affect. We excluded people who change status. Now, I think that they would be an interesting group to look at, and in fact, that would be looking at changes in the concession card rules would be something that would be of interest to us, because obviously, assuming that doctors know that people have changed concession card status, that would definitely impact on the incentives that doctors have. And so you would have, that would be a nice thing to be able to look at. I can't comment it within the context of what we've done, because we, in fact, excluded patients who changed concession cards because of their own change in circumstances, presumably, rather than a legislative change.
Yeah. So this issue of how doctors actually identify high and low income patients. One thing I was wondering was, could you look at changes in the out-of-pocket payments over time within patients? So is it to do with perhaps the frequency of visits, or just doctor getting to know patients?
Yeah. No, that is possible. Of course, it's we don't have really good information on the sort of reasons why that might occur. One of the limitations, and I should say, all the data we have through, whether it's 45 and up, Australian longitudinal study of women's health, it's fantastic, but there are some limitations. And one of those is that you don't really observe changes in health status at the same time as you observe changes in healthcare utilization or out-of-pocket costs. Because obviously the surveys only get taken every few years, or every 3 years for the women's health study, and every 5 or even longer for the 45 and up study. So it's hard to sort of totally observe what's happening in terms of people's health.
But you can observe how many GP visits, for example, a patient makes, and whether the out-of-pocket payment decreases maybe over time as they. No, that's absolutely possible. I suppose what I'm saying is that it's hard to account whether that's a needs-based change versus a whim of wanting more healthcare. Victoria Macrina has asked, do you have any details about the specialists who bulk bill? Do they tend to be from specific specialist areas, or are they spread across all specialist areas?
I don't. That's a really good question. I don't have that information by hand. What we do know is if you flip it the other way, flip the question the other way, is there is enormous variation by type of specialties in terms of the fees that they charge and the gap that they have. So if you use that information to also answer the bulk billing question, I would imagine that there would be. But yes, from memory, the neurological specialists charged a lot more and had higher gaps between high and low income patients than some of the others, like dermatologists, I think, were sort of towards the bottom of the rank. And so yes, there is within and across variation depending on specialty type.
Okay, and that answers Caroline Watt's question as well, actually, so that's good. Maybe just one last question. I was also related to specialists, but thinking about competition, and I suppose the hypothesis of the target income hypothesis might apply, that the specialists have got some target income in mind, and they set their prices according to the volume of activity that they have to meet that target income. So is there any evidence around that, and looking within geographical areas at specialists of the same type?
Yeah, I think it's a really good question. We won't be able to answer that with the data we have, or what we used for this purpose, because obviously the data we have is a patient-based survey. So we observe whatever healthcare that patient has, but we can't observe whatever doctor's utilization was for that whole thing. But of course, the Mabel data now has linkage to the Medicare data. So that's a really good question to ask of that particular data set, because there you do get complete information about a doctor's fee charging behaviours.
Yeah, but even within, I mean, I guess you've got a pretty big sample with your 45 and up. So, within, and it's all New South Wales. So,
yeah,
in different areas, you could look at the numbers of visits to different specialists of the same type within a geographical area and see if there's a relationship.
Yeah, so if you change the unit of analysis, then yes, that would definitely be doable. Yeah.
Yeah, so it would give you. So it wouldn't answer the question completely, but it would give you some indication of whether, those that are the price sensitivity. Which we would expect there to be very little, I guess. But, yeah. Okay. It's exactly 12 o'clock here, or 12:30 where you are. So we'll leave it there. So thanks very much, Keith. Fascinating talk. And for everyone else, the video of this will be online in the next few days. So feel free to let other people know about it.
Great.
Thanks.
Thank you.
Okay.
Thanks for listening.
Thanks. Sarah?
I have a local fan base.
Oh, yeah.
Right. Have we got any more lined up, Sarah, or not?
Yes, we do. We have the Commonwealth Fund talking to us about the Harkness Fund in a couple of weeks, and another event at the end of May that I'll send details out to delegates when I send the link for the video today.
Great. All right. Thanks.